Interpersonal therapy in bipolar spectrum disorder. Group 3, composed of Nayland Galbraith and Lori Jenkins. The objectives of this presentation: define interpersonal therapy and a history of the intervention, list treatment goals, objectives, and length of the intervention, understand the efficacy of interpersonal therapy across the bipolar spectrum, the clinical applications of interpersonal therapy across the bipolar spectrum, and an overview of bipolar spectrum disorder. Interpersonal therapy defined. The model was developed by Gerald Klerman. Interpersonal and social rhythm therapy, also abbreviated IPSRT, it focuses on daily rhythm stabilization. It consists of the premise that our daily routines impact our mood and the stability of mood. So there is a focus on sleep-wake cycle, exercise, meal times, our work routines, that when we can actively stabilize our routines, it will help to stabilize our mood. Interpersonal therapy usually consists of 12 to 16 weekly sessions characterized by an active therapeutic approach. It's based on two assumptions. One, that interpersonal discord is likely to be rooted in early dysfunctional relationships, and two, interpersonal discord are likely to be involved in perpetuating as well as precipitating the current depressive symptoms. Interpersonal and social rhythm therapy. The intervention was originally designed to be a one-on-one process, one therapist with one patient. It has since been adapted and used in different settings, including phone and group sessions. It consists of 3 stages: the initial, intermediate, and final stages. The IPSRT stages. The initial stage is information gathering about the current mood state and prior mood episodes. The therapist explores the behaviors and relationships associated with changes in the mood state over time. The clinician and patient agree on a primary interpersonal problem area as the main focus of the intervention. The intermediate stage. Tracking is captured in a form to document social rhythm regularity every week. This form is reviewed with the clinician on each visit. The clinician helps the patient regulate social rhythms and work on the selected interpersonal problem area. In the maintenance phases, the patient practices the skills learned during the program, and later during the phase of termination, IPSRT focuses on building the patient's confidence and developing skills to manage shifts in routine, such as vacations or job changes. Sessions are usually weekly, but change to bi-monthly or monthly during the latter phases. The goal of the final stage is to reduce the visits and eventually terminate the therapy. The patient should be able to monitor their progress, their patterns, their triggers with the tools acquired during their sessions. Success across the bipolar spectrum with interpersonal therapy. Controlled trials support interpersonal therapy as the most effective non-pharmacologic intervention for major depressive disorder, specifically in addressing interpersonal conflict. This is an evidence-based psychotherapy that has been modified for the treatment of bipolar II disorder. Applications in clinical practice. Interpersonal therapy can be an effective tool utilized by a trained therapist for patients across the bipolar spectrum and may have benefits in high-risk populations. This intervention is generally not considered to be a treatment replacement for medication in bipolar disorder. However, that is an area of debate. Goldstein et al. Concluded that IPSRT merits further study as an acceptable intervention for at-risk youth, a population as defined as having one parent with bipolar disorder. This therapy could potentially be used to delay or prevent syndromal hypomania in at-risk youth. Joining hands, culturally competent care. Cultural implications for psychotherapy. The therapist must be self-aware of their cultural identities and beliefs, which will allow them to be aware of differences in the perspective of the patient. Knowledge about the culture, beliefs, and practices of clients. Available of written material in native language and a translator during the encounter. Culturally specific interventions for the client. And use of the cultural formulation interview, which uses 16 open-ended questions to evaluate a person's health concern or symptom and the cultural beliefs regarding the health concern and treatment. We have listed for the group resources regarding IPSRT. To further your learning, there is a website, there is a manual, and as treating clinicians, when we're making referrals and discussing about therapy, it's beneficial to present all types of the therapy options and also have available a list of current counselors in your area for a resource for your patients. Networking is beneficial for all providers in a given area. One online resource in finding qualified therapists in your area is available through the Psychology Today website. Screening tools for bipolar or depression. We are familiar with these tools, the PHQ-9, which is very easy to administer in the clinic. This can be given to your clients prior to you seeing them. It's a great sounding board for kind of where they are in their mood and specific symptoms which seem to be prominent. Also the Beck Depression Scale and the Mood Disorder Questionnaire. Anytime that you are seeing a patient in the depressed phase, you should always consider bipolar disorder. Bipolar patients typically present during a depressive episode. It is very important that bipolar is identified as a possibility because, of course, medication, antidepressants can throw them into a bipolar mania swing. Clinical presentation of a bipolar patient. Age of onset is typically in the mid-20s. It can be present in teens. Bipolar affects men and women equally. The incidence in the U.S. of adults is 2.8%. 83% of the cases are considered severe and having severe impact on mood having severe impact on functioning in daily life, whether it be on the depressive end or on the manic end. The presentation can be diverse depending on where the patient is in the bipolar spectrum. Who am I today? This is what our patients think every morning when they wake up. Bipolar disorder is a disorder of instability, awakening in the morning and not knowing what the day is going to bring. You know, our patient may awaken to bright and sunny skies, fluffy clouds, full of life and energy, or our patient may awaken as if the dead of winter and there is no warmth, there's no sunshine, and all their life has been drained from them. Some of our patients have rapid cycling, which would be like a windstorm that blows them from one weather to the next rapidly, just like it occurs in our weather. And today they feel this way, and tomorrow they're in the depths of despair. It is very life-interrupting to not know who I'm going to be when I wake up. We have listed the DSM criteria for mania, for hypomania, for major depression, and then for bipolar 1 and bipolar 2. The criteria for the disorders are on the following slide. I'll briefly highlight parts of the criteria, but I'll not bore you by reading them to you. At the end of the reference page is a complimentary DSM-5 desk reference from us to all of you, and we hope this presentation has been informative and stimulates learning about interpersonal therapy as a treatment for bipolar disorder. Mania, elevated mood or irritability. It can be a bright mania, it can be a dark mania, but there's increased energy and lack of need for sleep, and it must last for a period of a week. It must be present most every day, nearly all day. Mania can be identified if a hospitalization is required, even if the time duration is short. Mania criteria B. During this period, 3 of the following must be present. If irritable mood is dominant, 4 of the following must be present. Grandiosity, lack of need to sleep, rapid excessive speech. Those are just a few. Mania criteria C and D. Criteria C, there must be a marked impairment in social or work relationships and performances. Criteria C is met if hospitalization is necessitated to prevent harm or if psychosis is present. Criteria D, we must always think of other things that can cause this mood condition and be aware it could be initiated by an antidepressant or ECT, but using clinical judgment, if the manic phase continues longer than would be expected, that indeed it may represent a bipolar 1 rather than just drug-induced. Hypomania is just not quite as severe as mania. The mood changes may be present about 4 days, and it has a less significant impact on our work and social relationships. Criteria D, these changes must be noticeable by others. Typically, criteria E, there's not marked social impairment, and that is a real difference between mania and hypomania, of course not affected by any other condition. A full manic episode that begins during the antidepressant period but continues after we would have expected the results to have resolved can be diagnosed as hypomania. Clinical judgment is used at that time. Major depression, we have looked a lot at major depression. This must last greater than 2 weeks. Depressed mood or loss of interest, one of the two must be present. It must be present most every day. Here's physical manifestations. Once again, there must be an impairment of social relationships, not another medical condition we need to consider. Major depression is common, but it's not required for bipolar 1. Some patients tend to spend more time in the manic phase rather than having severe depressive stages. We always have to look at losses and trauma to see if they might be responsible for the depression. At that point in time, we would consider it an adjustment disorder. Grief would be one of those losses. And here is a discussion of grief and how these symptoms can be different from major depression. Bipolar 1, criteria A through D for mania have been met at least once currently or in the past. They may have had a prior manic episode that when you begin to interview them, they didn't even realize that there was anything wrong with that behavior. but they can think back and say, yeah, that has happened before. Bipolar 2, criteria A through F have been met for at least one hypomanic episode and at least for one major depressive episode. But there has never been a manic episode because that would distinguish it from bipolar 1. We've enjoyed developing the presentation. We hope it's given you a good start in understanding the use of interpersonal therapy with bipolar disorder. Next week, our semester is half over. Good luck on the exam, and remember about the PDF copy of the DSM-5 desk reference at the bottom of the reference page on the transcription. Signing off, this is Lori Jenkins speaking for myself and Maylin. Here are our references. Have a good week.